So we are live.
Thank you, Rajneesh, and thank you everyone for joining. Good morning, good afternoon, good evening, wherever you are around the world. We have over 4,000 people who've come together today to hear our top panel and find out all about how to manage and how to image cesarean scar pregnancy. So I'm joined here by my co-chairs, Baski, hi Baski, and Prashant, and we have with us Professor Ilan Timo from New York, Davor from London, Judith from the Netherlands, Amar from the UK in London, Andrea in the UK at the moment, and Laura, who used to work with us until recently but has abandoned us to go to Belgium. As you all know, we started this adventure of Scan.Academy during lockdown in order to bring people together. And this was exactly our aim, to bring the top people together to talk about the most recent evidence, but also research. And I'd like to thank very briefly our sponsors, GE, who with their generous contributions allow us to run these webinars free of charge to you. Just a very quick announcement: on the 10th of April, at 12 noon in London, I haven't worked out all my time zones yet because the clocks change, we've got a gynae ultrasound program. And this is a sort of program that is useful for me because it's what everyone should know. This is not super high level. This is kind of at the level that even an obstetrician should be able to tell the difference between something that looks terribly benign or terribly malignant in an ovary. And Wouter Freumann will talk to us about that. Lil Valentin will talk to us about abnormal bleeding, both pre and post-menopausal. Matthew Leonardi will talk a little bit about the initial assessment by ultrasound of the fertility patient. And Simon Ma will bring it all together with a beautiful discussion. Just one quick word on certificates of attendance. If you want a certificate of attendance, please make sure you spell your name as you want it to appear on your certificate. I'm hearing some music in the background. I don't know if others can too. Through the program today, you're going to see these little QR codes. So it's just for you to know how to deal with a QR code in case you don't have teenage kids in the house who tell you how to do that. What you need to do is take a picture of them, or rather point your camera of your iPhone or your Android phone onto the QR code. And it's by magic, a little web link will open. And if you click on that web link, it will allow you to take part in this short online survey of the management of cesarean scar pregnancy. I tried it and it works. And there's another QR code as well, which will allow you to take part in this exciting venture that our speakers will be talking to us about today. So that's all I really wanted to say. And I think I'll hand over maybe to Baski. Baski, do you want to say a few words about your CSP program and also maybe to introduce the first speaker?
Unmute. Thank you very much, Aris. It's paradoxical that in this sort of global seminar we have with 4,000 people, that it takes me to talk to the person I share the office with, Aris, to be able to facilitate this webinar and this great opportunity for us who are interested in cesarean scar pregnancy. So for me, the physical world is still really, really important. We have limitations now, but we hope today to bring you a whole process. Cesarean scar pregnancy is often thought of rare as being rare or insignificant, but I think you will see from today's talks that actually it's far more prevalent, far more important, and the correct management is still a matter of great discussion. I don't want to waste time because we've got some eminent speakers here. You don't need to listen to me, and I'll introduce them as they go along. First, we have Judith Hearn, who's the head of gynecology and vice president of the division of mother and child care at the VUMC in Amsterdam. She was past president of the Dutch Society of Endoscopic Surgery and is currently head of the ISWOG uterine niche task force. And Judith is going to talk to us today about diagnosis of niche and CSP diagnosis. Judith, thank you very much indeed.
Well, thank you very much. It's really a pleasure to participate in this great webinar. And I'm really impressed by the number of participants that are currently listening to this webinar. I'm asked to focus on niche leading to cesarean scar pregnancy, in particular on ultrasound features and staging of cesarean scar pregnancies. I will try to open my presentation. I've no disclosures to mention apart from some research grants that I received related to this topic. A niche is very prevalent, and we performed 2 cohort studies, and we identified niches in approximately 60% of the women using sonar hysterography. And
Judith, I'm going to just stop for 1 second. Judith, we can't see your slides. Can you?
Oh, sorry.
Try to reshare perhaps?
Yes, let's try to. Apologize.
That's okay, don't worry. It's always it's not always obvious whether people are just still speaking or trying to share slides. Now we can see them. Perfect.
This is better. Okay, thank you. As I discussed, niche is very prevalent, and it can be identified in approximately 60% of all women using sonar hysterography. And the same numbers are identified in 2 other cohort studies, but these are all niches with a depth of at least 2 millimeters. So this includes also small niches. And if we focus on the more large niches, then this could be identified in approximately 24% of all women. A niche can be easily recognized using ultrasound in case there is already fluid or blood collection in the niche. Here you see a uterus in a retroflected position, and this is in the transversal plane. A niche can also be identified using hysteroscopy, but then it's always advised to combine it with ultrasound in order to measure the thickness of the residual myometrium. And you can also use MRI scan, but in fact, I think that there is no beneficial effect of an MRI over normal ultrasound. And ultrasound is even preferred because it's more dynamic. A niche, if you apply saline or gel, then a niche can be better identified, in particular if it's a small niche. So in women with symptoms, it's advised to use sonar hysterography rather than normal ultrasound to identify the niche. To define uniform definitions and measurements, we performed the Delphi procedure among experts, and we focused on measurements of niches in non-pregnant women. And a niche was defined as an indentation in the myometrium with a depth of at least 2 millimeters at the site of the uterine cesarean section scar. We subclassified niches in a simple niche, so this is a niche without a branch, just an indentation, or a niche with 1 single branch, or a complex niche if there are more branches. The most important measurement to measure if you evaluate a niche is the thickness of the residual myometrium. So this is the thickness between the niche and the outer part of the cervix, because that's important if you consider treatments or for future research perspectives. Other basic measurements that are advised to measure in the sagittal plane is the length of the niche and the depth of the niche, and in the transversal plane, the width of the niche. Tips and tricks provided is that you should use GIS or CIS, so install saline or gel if there's no fluid in the uterine cavity. Vary pressure with the probe to evaluate the niche, because then you get better visualization. Use both the sagittal plane and the transversal plane and search for the most optimal plane to evaluate the niche, and measure both the main niche and the branches. If you want to have more details on niche measurement, if you're interested, you can use this link, but it will be working tomorrow, so don't use it today. And then you can use this e-learning that we developed for free. Only recently we know that a niche is associated with long-term symptoms. In particular, the most prevalent symptom is postmenstrual spotting, but also dysmenorrhea. And recently we've shown in a large cohort study that it's also associated with lower implantation rates and lower ongoing and live birth rates. And it's also associated with uterine rupture and cesarean scar pregnancy. That's what we focus on today. And what is the pathophysiology of cesarean scar pregnancy? Well, I think this is actually not known yet, but you can imagine that if there is a very large niche, that an embryo, in particular if it's combined with intrauterine fluids, is more easily directed towards a niche. So, in my opinion, a combination of a large niche, intrauterine fluid accumulation, in combination with uncoordinated uterine contractions, may give a higher risk on niche pregnancy. On the other hand, we also know from a study from Osama Naji that if an embryo implants at the site of the niche or in the niche, that the risk on the miscarriage is very high. So 7 out of 8 pregnancies that implanted in the niche ended up in the miscarriage. So apparently the niche is not a very optimal environment for implantation. And it could be that smaller niches have a higher risk on ongoing pregnancies and larger niches are related to miscarriages, but we do not know this information. And therefore it's very important that we all register in the Cesarean Scar Pregnancy Registry to collect this information. Then the ultrasound evaluation of cesarean scar pregnancy, I think it's very important. It's very important to detect it in the early stage to avoid potential life-threatening complications. And Professor Timotrich already showed in a nice systematic review that approximately 40% of all cesarean scar pregnancies are misdiagnosed as miscarriage in progress, and then it might be related to complications. Because if you're not aware that it's a cesarean scar pregnancy, there is a higher risk on extensive blood loss and perforation. We performed a Delphi procedure among niche experts to classify cesarean scar pregnancies and to define ultrasound measurements. We had 4 rounds to achieve consensus, and a cesarean scar pregnancy was defined as a pregnancy that's located at the site of the uterine cesarean section scar. And it was defined to exclude the cesarean scar pregnancy in all women with a previous cesarean section. So be aware if you scan a woman with a previous cesarean section, and evaluate in both directions, in the sagittal and in the transversal plane, and use color Doppler, because it makes it more easy to identify a cesarean scar pregnancy, but it also allows differentiation with an ongoing miscarriage. And it also allows you to evaluate the localization of a cesarean scar pregnancy in relation to the uterine arteries. Here you see a patient who was treated with MTX, and 1 day later she had severe pain, and then we saw a cesarean scar pregnancy very close to the vessels, and because of we were afraid for a rupture, we performed a laparoscopic niche resection, and we could identify here the cesarean scar pregnancy. Here you see the cervix and the bladder, and it was protruding towards the side wall, but there was no rupture at that moment yet. The results from the Delphi procedure, it was we asked them, the experts, what's the best moment to evaluate a cesarean scar pregnancy? And it was consented that it's around 6 weeks, but of course it depends on the moment when a patient enters your clinic, when the evaluation can be performed. And as I discussed, it is important to evaluate the entire uterus, so not only the fetus. This is a patient who was referred to our clinic at the gestational age of 12 weeks. And she had already a few days of misoprostol induction because it was an undesired pregnancy. She had pain, but without a miscarriage. And then we evaluated, we zoomed out, and it turned out to be a Cesarean scar pregnancy. So it's important to evaluate the entire uterus and to focus on the localization of the pregnancy and trophoblast invasion. You can also use, of course, 3D ultrasound, but that's not really obligatory. Within the Delphi procedure, we also classified the Cesarean scar pregnancy, and the main differentiation is between the type 1 and type 2 pregnancy. It was defined that the type 1 pregnancy is a pregnancy where the pregnancy is located more than 50% towards the cervix or the intrauterine cavity, and that is less than 50% embedded in the myometrium. And in case of a type 2, more than 50% of the pregnancy is embedded in the myometrium. Here you see an example. This is a Cesarean scar pregnancy. You can see that less than half is embedded in the myometrium. So this is a type 1 Cesarean scar pregnancy. Here an example of a type 2 pregnancy, more than a half embedded in the myometrium. So here, type 2. We also subclassified the type 2 pregnancy. If the pregnancy is located within the outer contour of the cervix, it is a type 2A. But if it's progressing towards the bladder outside the imaginary contour of the cervix, it's a type 2B. Here you see an example. This is more than 50% embedded in the myometrium, so it's a type 2, but it's within the outer contour, so it's type 2A. And here again, the type 2B, because it's more outside the imaginary contour of the cervix. It's important to realize that the classification, that it may change during pregnancy. Here you see the same patient, and in the beginning, it is a type 2A, and then later on, it progressed towards type 1. So it may change. I will not focus on treatment today because there are many excellent speakers with more experience concerning treatment in Cesarean scar pregnancies, like Professor Jurkovic and Timotric. But I only show you that we use the classification to counsel the patients and to discuss with them which type of treatment we are going to apply. So if it's a type 1, we counsel them that it could be expectant or curettage. Type 2A, we advise them to undergo curettage in combination with a cerclage. And a type 2B, we consider a laparoscopic niche resection. But as discussed, this is all under debate. What's the most optimal treatment? And this, of course, also depends on the experience. I think that it's important. I'm not going into detail into this flow diagram, but the most important message that I would bring today is that if you have Cesarean scar pregnancy, please refer the patient to a center with a lot of expertise to discuss the diagnosis and the type of treatment. In conclusions, niches are very prevalent and associated with long-term complications. It's important to exclude the Cesarean scar pregnancy in all women with a previous Cesarean section and use color or power Doppler. A Cesarean scar pregnancy can be classified in the type 1 and type 2 Cesarean scar pregnancies. Most Cesarean scar pregnancies end up in a miscarriage, but we need more data. So I really hope that a lot of centers will participate in the Cesarean scar pregnancy registry. Thank you very much.
Thank you very much, Judith. Rajneesh, you need to let me. Okay, you're on Aris rather than me.
That's okay.
Judith,
Maybe
thank you
I
very
can
much
ask,
indeed for that.
maybe I can ask a question to Judith since
Yeah.
since I'm here.
Yeah, got it.
The,
Thank you very much.
the ability
That was
to,
a very clear and logical presentation, and really just what we needed. There are a couple of questions that are outstanding. One that got sent to me. The subclassification for 2A, 2B, Judith, is it possible that 2B is just a more advanced gestation of 2A and not really a different classification?
Well, of course, it may 2A with advanced gestational age may become a 2B, but sometimes already very early in this gestation. So even at the gestational age of 5 weeks, it may be a 2B. And I think that depends on the size of the niche where the cesarean scar pregnancy is located in. So it could be already early in pregnancy, that's a 2B. And sometimes a 2A pregnancy with advancing gestational age progresses towards a type 1. So it depends on the direction where the pregnancy is going towards. So if it's progressing towards the bladder or going more into the uterine itself.
Yeah. So you made a fantastic case for gestation being a confounder for classification, and that perhaps gestation needs to be considered, or the classification needs to be considered in the context of gestational age. Is that right?
I fully agree on that. And I think that's something we should add and take more into consideration.
Okay, that's fabulous.
I have a question from Mustafa Madad from Egypt. Thank you for joining, Mustafa. So you do a scan and you incidentally or accidentally discover a niche. The patient is completely asymptomatic. They don't plan for any future pregnancies. Anything to do, or can you just leave them alone?
Well, we advise them only treatment if they have symptoms, because at this moment we do not know if there's any beneficial effect of doing a laparoscopic niche resection in women without any symptoms. But and it's also difficult to say what to do in women with subfertility, for example. If they have subfertility and a large niche, should we treat them, yes or not? And I think so far we do not have the answer. And currently we're performing a randomized control trial in which we randomize women for immediate laparoscopic niche resection within 6 weeks, or to advise or expective management for at least 9 months. And then we hope that we get the answer. And at this moment we included 100 patients and we want to include 200 patients in total. So then we hope that we will have the answer concerning the additional value of laparoscopic niche resection concerning subfertility. But what to do in women with a very large defect without subfertility, we also do not know that yet. And that's the second randomized control trial that we apply. We randomize them in the laparoscopic niche resection or expective management for at least 1 year. And we follow them up also during pregnancy.
Sorry to interrupt, Judith and Ilan. Could we reserve this for the end? Because these discussions will be far more informed at the end rather than now. So we are jumping ahead of the gun and anticipating what may happen in some of the other talks. So
I think that's very useful, Baski. I'm just going to sneak one last question in because it's a quick answer from Sherry May from Saudi Arabia, who asks, how long after a cesarean section do I need to wait for the healing process to be completed? Or in other words, I guess, when is it a niche and when it is still in the process of perhaps getting better on its own?
If there's a niche, it's not getting any better. It's only getting worse, because we performed repeated measurements. And if you perform a measurement at 6 weeks or 3 months or 1 year, the niches become larger at 1 year. So they don't get smaller. But that's not an answer how long you should wait for the healing to be optimal. And I think you should wait at least a half a year, but maybe 1 year. And I'm not, probably Professor Baski or Dimitris can answer that question better.
Okay, well, that's an interesting one. How long do you wait and should you repair it? I think are still important questions to be answered. I think we should, because we have so many good speakers and I don't want to cut them out of their due time, I think we should move on. Judith, we're going to come back to you, so don't disappear, please, if that's okay. All right, great. Next up, we have Amar Bidet. I have the pleasure of working with Amar at St. George's. He's a consultant. obstetrician and fetal medicine with me. He is also the deputy editor-in-chief of ACTA, Obstetrica and Gynecologica Scandinavia, and really quite an internationally recognized expert in placenta accreta spectrum. Amar, we've asked you to talk about placenta accreta because we all now acknowledge that that is the consequence of a certain proportion of CSP diagnosis made in the first trimester. Thank you, Amar.
Bashki, thank you very much for the kind introduction. Can you see my slides, Don, Laris?
Yes.
Yeah, we can see your slides, yeah.
Fantastic. Thank you for the kind invitation to talk about expectant management of cesarean scar pregnancy and placenta accreta spectrum. In some ways, I'm feeling like an odd man out because I don't really see cases with cesarean scar pregnancy. What I do see is the result or sequelae of a cesarean scar pregnancy, and I've got to deal with it, and that's one of the reasons I think I've been asked to speak about it. So to summarize the scope of my talk, I talk a little bit about natural history of cesarean scar pregnancy, treatment options for the sequelae of cesarean scar pregnancy, that is the placenta accreta spectrum. I'll touch a little bit on screening for cesarean scar pregnancy, should we or should we not? And lastly, I would tell you a little bit about our experience about screening for placenta accreta spectrum in pregnancy. So that's in short a summary of my talk today. Right at the beginning, let's revise the diagnostic criteria for cesarean scar pregnancy. And to begin with, we weren't quite sure as to what the diagnostic criteria should be. But now the diagnostic criteria are fairly uniform and well recognized, that the upper uterine cavity should be empty. The gestational sac or trophoblast should be located anteriorly at the level of the internal os, covering the cesarean section scar. The myometrium between the gestational sac and the bladder should be thin or absent, and there should be prominent trophoblastic or placental circulation around it. Finally, the endocervical canal should be empty. So these are the criteria which have been used for calling as a pregnancy a cesarean scar pregnancy in majority of the publications that I have seen. Now, in 2020, the Society for Maternal and Fetal Medicine in America came out with this document, a consult series about cesarean scar pregnancy. And in this document, they realized and acknowledged that there is limited information about this one, particularly the natural history. And the majority of the reasons, the main reason for that is the vast majority of these will undergo termination. So we don't know what happens to them had they not been terminated. But they realized and acknowledged that there is a high risk of severe complications in the second and the third trimesters, and there is a high risk of subsequent development of placenta accreta spectrum. So all this has been recognized and acknowledged in this particular document. Now, this paper published in 2015 comes from the group of King's College. Nurit published this in 2015, and that's one of the first ones I have seen about natural history of early first trimester pregnancies implanted in cesarean section scars. And the criteria I told you about earlier on have been taken from this paper. Now, it is quite interesting to see the data that the authors published in this paper. They followed up 10 women diagnosed with cesarean scar pregnancy, and they were managed conservatively because these women did not want to undergo termination. So 5 of these women ultimately had placenta previa. 5 of them, of the 10, required a cesarean hysterectomy. What's important is the complications. Urological injury was noticed in 5 of them. 4 of them, bladder was injured, and 1 of them, bladder and the ureter, was injured. 6 women showed placenta accreta spectrum on histopathology. All but 3 women had either a blood loss of more than 1.5 liters, or a urinary injury, or a hysterectomy. So we can see that 70% of them have had severe complications as the pregnancy progressed. The second paper that I have selected for this is Cesarean scar pregnancy in the UK, a national cohort study, and this was published in 2018. And they followed up 21 cases of Cesarean scar pregnancies that were managed conservatively. Now, 9 of them had cardiac activity and a live birth. So 5 of them with cardiac activity had a live birth. 3 underwent cesarean hysterectomy. 2 of them with estimated blood loss of 15 liters and 20 liters. 1 went through an uncomplicated pregnancy. And the last one, it's an interesting one. It was a heterotopic pregnancy. So the non-viable cesarean scar pregnancy was non-viable, it didn't continue. The other pregnancy, heterotopic pregnancy, continued till term and was pretty uncomplicated, but actually, I don't think this counts as a cesarean scar pregnancy. So one can see that, the vast majority of them end up in severe complications as the pregnancy advances. So now there is a fair amount of literature which shows that a cesarean scar pregnancy, if untreated, there's a high chance, 70-80% chance that they will end up into placenta accreta spectrum as the pregnancy advances. And this is what we see if we don't treat the case, and this is what I see. These are the pregnancies that I see. And here is a grayscale image, and on grayscale itself, one can see that there is placenta previa. The placenta has multiple lacunae. I haven't actually put color on, but this picture is good enough. Clip is good enough to tell me that we are in trouble. This is a case which is highly likely to have severe complications as the pregnancy advances. Let us talk a little bit about management strategies for placenta accreta spectrum. And at the moment, we know that there are several options available to us: hysterectomy, fundal incision and leaving the placenta in situ, a staged procedure, so fundal incision and leaving the placenta in situ, and then go back and do a hysterectomy, and finally, partial myometrial excision, a conservative type of surgery, what is called as a triple P procedure that originates from my hospital, St. George's Hospital. At the moment, we don't actually know what is the best way to treat cases where antenatal diagnosis of placenta accreta spectrum has been made. And this document, placenta accreta spectrum document, comes from Society for Maternal-Fetal Medicine in 2018 and Obstetric Care Consensus. And they say that the most generally acceptable approach to placenta accreta spectrum is caesarean hysterectomy with the placenta left in situ after delivery of the fetus. Worldwide, this is the most commonly performed procedure for placenta accreta spectrum. But let's see what happens to these cases where the primary treatment is hysterectomy. And here is some of the series. The latest one, 2020, 34 cases, cystotomy in 2 maternal deaths. Shamsirsas, this is one of the biggest ones, comes from Houston in America, 118 women operated, cystotomy 41, ureteric injury in 2. Fitzpatrick comes from the UK, 79 cases operated, ureteric injury in 10, fistula in 4. So you can see that, operating on them, doing a hysterectomy is associated with a fair amount of operative complications in them. What about partial myometrial excision? What can we do with that? And this is a series. Again, the biggest series comes from Jose Palacios from Argentina. And he reported on 326 women, but some of them had undergone hysterectomy. 98 of them had undergone hysterectomy. Majority of the complications that he is describing happened in this group, hysterectomy group. 47 cystotomy, 4 ureteric injury. Our group from St. George's reported our experience of 50 cases, first 50 cases, and we reported cystotomy in 1, reoperation in 1, thrombosis in 3, but we did not report any ureteric injury. So in our hands, the rate of complications is fairly low with partial myometrial excision. The advantages of partial myometrial excision are fundal incision improves access, devascularization limits blood loss, retaining minimal placental tissue limits delayed complications such as sepsis and secondary postpartum hemorrhage, and future childbearing is not the primary objective. We are not doing this in order to preserve fertility. We are doing this in order to reduce surgical complications. Now let's see what happens to those where the placenta is left in situ and not taken out at all. So here is there are some numbers. The latest figures are from 2019, 156 women, 21 of them needed delayed hysterectomy. And if they did need a hysterectomy, the surgical complications happened. Cystotomy happened in 37 of them. 2 women lost their lives. And you can see that reoperation is often required because of sepsis or hemorrhage, secondary hemorrhage, and then surgical complications do happen in those where the placenta is left behind. Here, out of 167 cases, you can see, again, this is the French group, severe maternal morbidity was seen and delayed hysterectomy was needed in 36 of them. So at the moment, we don't know what is the best way to treat them. We know that there are several ways, but we don't have an firm answer right now. That brings us to some of the questions. Should we screen for cesarean scar pregnancy? Is early detection and treatment less risky? And should we screen for placenta acquita spectrum? So there are some factors or some arguments for screening. That's yes for screening. We know whom to screen. Women with previous 1 or more cesarean delivery is an at-risk group, and we know that they have a higher chance of developing a cesarean scar pregnancy. High proportion of pregnancies with cesarean scar pregnancy will proceed to placenta acquita spectrum, and we know that. The rate and severity of complications increases in later pregnancy, and the management of cesarean scar pregnancy in the first trimester is much less risky. I'm not going to go into details about that, and we've got excellent speakers to follow, and we will learn from them how cesarean scar pregnancy should be managed. But this is the only one side of the coin. There is the other side of the coin. Whom to screen is uncertain, and why I'm saying that? Because not all cases of placenta acquita spectrum have got a previous cesarean section. And if we look at published series, up to 50% of them don't have a cesarean section or placenta previa. So skeptics might say that actually, even if you screen all women with previous cesarean section, you're not going to target every case with a placenta acquita later on. There will be a significant increase in workload for ultrasonographers and their trainers, because they have got to be trained properly in order to correctly identify a cesarean scar pregnancy. The hit rate is likely to be low. Most pregnancies following a cesarean section are not going to be placenta acquita spectrum or cesarean scar pregnancy. They are likely to be intrauterine normal pregnancy. Some pregnancies, even if they are diagnosed or detected to have cesarean scar pregnancy, will not develop placenta acquita spectrum. And at the moment, we don't know which one will and which one won't. Finally, there is little evidence that screening does more good than harm. So there are, arguments on both sides of whether or not to screen for cesarean scar pregnancy. That brings me to my final point: should we screen for placenta acquita spectrum? And I wanted you to take through our experience, which we published early this year, on screening for placenta acquita spectrum in women with low-lying placenta. So women undergoing screening ultrasound, and we included 57,000 of them. Now, placenta previa in the 3rd trimester was diagnosed in 220, and that brings us to the prevalence of about 4 in 1,000, which kind of matches what has been reported in the literature. So we weren't missing, we weren't excessively diagnosing women with placenta previa. So these are women with placenta previa. Now, out of these 220 women with placenta previa, 75 of these had previous uterine surgery. And of these 75 women with previous uterine surgery, we had 21 out of the 22 cases of placenta previa spectrum, and they were correctly diagnosed when they were referred to the placenta previa diagnostic service. There was only one woman with placenta previa spectrum who did not have a previous cesarean section, and she had a previous myomectomy. So this is the experience from St. George's about screening program. And what do we learn from it? We learned that 1 in 5 women had previous cesarean section in our cohort. The overall risk for placenta previa spectrum in these women where placenta previa is diagnosed at 32 to 34 weeks was about 5% overall across the board. We know that 20 out of 22 cases of placenta previa spectrum had a previous cesarean section. We know that in this group, the risk for placenta previa spectrum, if a woman has had a placenta previa and 1 previous cesarean section, is 15%. That risk increased to 37% with 2 or more cesarean sections. So this is our experience about screening of women with previous cesarean section and placenta previa to detect a placenta previa spectrum. And I hope I've convinced you that in the large majority, we will be successfully detecting them in time. Thank you very much.
Thank you very much. Thank you very much, Amar. That was masterful about placenta accreta. Just a couple of questions. You showed some convincing data that placenta accreta spectrum should be screened for. And am I right that that paper shows that you must look for placenta accreta spectrum in women who have both a placenta previa and a previous cesarean section? That was the most efficient way to screen for placenta accreta.
Right. Yes.
Okay. And then you showed quite large data sets. And of course, we're not comparing apples with apples. Some may be different cohorts, but quite large data sets to look at myomectomy, myometrial excision versus hysterectomy, hundreds of cases. But when you come to tell us about what happens to CSP, the number was 5 and 10. Can you be certain about the risk? I'm not arguing with the fact that CSP ends up with placenta accreta spectrum, but can you be certain about the risk that you tell women for placenta accreta when they have a cesarean scar pregnancy?
Basky, I don't know. I can only tell women what has been reported.
Great.
And I showed you what has been reported. The large majority will lead to placenta accreta spectrum if you don't treat them. And that's one of the reasons why a large majority of them will not proceed. They will be terminated.
Okay, so that's why you need to stay on and listen to the next talk. Aris, have you got anything on your screen from that magic screen of yours?
There are hundreds of brilliant questions here, but many of them we will be picking up during the next talks. So okay. I'm going to reserve them. I do want to, though, return at the end of all the talks to this crucial question of, you have a CSP. The woman has an ectopic in the cesarean scar. It's a desired pregnancy, very much a desired pregnancy.
Yeah.
You know, how does your counseling go? Because the mother may say, well, do you know what, doctor, if I end up with a hysterectomy and a healthy baby, that's fine with me. You know, I'm not interested. And that is, you know, for me, a really crucial issue is, can we distinguish those cesarean scar pregnancies that are going to really lead to major hemorrhage during mid-gestation and sort of catastrophic outcomes, versus those women who will actually end up with a live-born infant at the end of it, even though that will mean pretty, you know, valiant surgery at the other end of the gestation. I would love us to try and dissect that. And I know that the data are not there, but if the heads that I have with me today cannot answer that, then I think
we're going to go halfway there, Aris. We're going to get halfway there. So that leads us very nicely to the next. Andrea Kalin, in recognition of the complete lack of data all the disparate amounts of data from all over the world to do with Cesarean scar pregnancy, 2 years ago helped look for money and set up the Cesarean scar pregnancy registry. Now, this is a global registry which has been running over a year, and we have now 2 of the doctors that run the registry who are going to speak on global variation and try and answer some of the questions you have so far based on the data they have. It's a double act. We're going to have Dr. Laura Noel, who is a consultant in obstetrics and gynecology from the University Hospital of Liège. She's a co-investigator on the CSP registry, followed then by Andrea Kaelin, who is set up the registry, who's a subspecialty trainee in maternal fetal medicine at Nottingham University Hospitals here, and she's the principal investigator. I don't know if you want, Andrea, you're going to share the slides and Laura's going to kick off, if that's right. Okay.
Andrea, several of the people in the chat are as slow as me with their phones, so have requested when the little QR code comes up, just to stay there for more than just 5 seconds to allow them to.
Yeah, I'm going to put it up for about 2 minutes at the end as well, so we'll have lots of time.
And there are two QR codes, one for the quiz and one for the registry. Thank you.
Okay. So hello, everyone. Thank you all for being here today. It's such a great opportunity for us to present the Cesarean scar pregnancy registry with over 4,000 people listening. So I will start with an overview of the registry, and then I will hand over to my colleague, Andrea, and she will present you a preliminary analysis of the registry data. So the CSP registry collects data on the diagnosis, the behavior, and the management of Cesarean scar pregnancies. And these data will be used to improve the outcomes of CSP cases. And we wish to inform the clinical management and to enable multi-center collaboration in the future. So the success of the registry depends on the voluntary collaboration of doctors to share their cases. Yeah. So the CSP registry is accessible online through www.csp-registry.com. The registry collects retrospective data from 5 years back, and all these data are completely anonymized and de-identified. This study is approved by the Ethics Committee of St. George's University in London, and all the data are stored on a secure online platform that is managed by Adjumed. If you are interested to take part in the registry, you will first have to seek a local approval from your institution to share your clinical data with us. And then we will ask you to upload an ultrasound picture of each CSP case, and this is for diagnostic accuracy. The registry collects data on the diagnosis of the CSP with the symptoms, the ultrasound features, and also the beta HCG levels. We are also interested in the treatments, whether it was an expectant management or a termination of the pregnancy. And finally, we are also collecting information on the outcome of the pregnancy, if it was continued, or on the safety and efficacy of the chosen method for the termination. So to date, we have 335 cases registered over a period of 1 year. And this is thanks to 19 centers that have already uploaded their cases into the registry. And you can see on this world map that the 19 centers are shown by the red dots. We now have 35 more centers that are currently onboarding. And these centers are from 13 different countries that you can see in blue on this world map. And so we are really optimistic that we could reach over 600 cases by the end of this year. So this is a picture of our team. So Baski is the chief investigator from the UK. Ilan is the principal investigator from the US. Wilhelm is responsible for day-to-day management of the registry. Then Gwendoline and myself are welcoming the new centers and providing medical support. And finally, Andrea is the one who has initiated the registry, and she is the active lead for the project. And so I will now hand over to her, and she will present you the first analysis of the registry data. So over to you, Andrea.
So thank you very much, Laure. It is really, and we are an amazing team, and it is really a pleasure for me to present the first data of the International Cesarean Scar Pregnancy Registry. And I'm going to speak about global variation in care, as this is a global webinar. So for the purposes of this webinar, I'm going to really focus on the data of North America, Europe, and Africa, as these are where most of our centers are from. And as you've heard, we've had more than 300 cases, and most of them are type 2 CSP, so in the niche, as you have heard from Professor Hueren before. So these are the ones that implanted deeply in the uterine wall, in the scar. So 1/3 of our cases are the type 1s and on the scar. And as you can see, 95% of our scar pregnancies that we have collected are classified. Most of the women that we have collected have presented with symptoms when they were diagnosed with their cesarean scar pregnancy. Especially in Europe, almost 70% of patients complained of bleeding, pain, especially abdominal pain, or a combination of both. And also over the other continents, pain and bleeding seems to be the majority of the symptoms. As you've heard, and Amar already spoke about expectant management, and Professor Timur Tric and Professor Jurkovic will speak about termination. But we can see here also in our registry data that 3/4 of women in North America and Africa are undergoing elective termination. In Europe, there appears to be an almost equal distribution between now expectant management and termination. So I'm going to speak about expectant management, and especially about women that had a viable scar pregnancy. That means women that had a scar pregnancy with a positive heartbeat. When they were followed up, about 1 in every 5 women had a spontaneous miscarriage. And of those that continued to birth, every second one of those women had an AIP in our data. When we look into the 2 types that Professor Hueren described before, then we have the type 2 in the niche and the type 1 on the scar. And in our cohort, 2/3 of the patients within the niche pregnancies that continued had an AIP confirmed at birth. There is also, interestingly, really a global variation in the methods of termination. Especially in Europe and North Africa, suction evacuation was the preferred method of termination. In our centers in the US, we have used the double balloon also quite frequently. And overall, globally, 1 in every 4 women has systemic methotrexate as a method of terminating her scar pregnancy. There are other methods I'm sure you are all aware of, which are local injection of KCL or methotrexate into the gestational sac, or uterine artery embolization. But in our cohort, they were much less used and only account for about 10 to 15% of cases. So I'm going to speak about medical management for the next 2 slides, because as we have seen, there is a lot of interest in that, and actually it's still used quite frequently. We looked at success and the need for secondary treatment for in the future to help us choose which women might be suitable for that. But for now, what we have found is that 3/4 of women that had a positive heartbeat and were treated with methotrexate were not sufficiently treated and needed secondary treatment. This was also the case if the CRL measured more than 6 millimeters, which was our 50th centile, and 6 weeks is 6 millimeters is 6 weeks and 6 days pregnant. So if the CRL measured more than 6 millimeters, 85% of women needed a secondary treatment. And we looked at beta ICG levels and their influence on the success rate of systemic methotrexate. And we used an arbitrary cutoff of 5,000. And if it was above, then also 2/3 of women needed an additional second-line treatment because they were not sufficiently treated with methotrexate alone. So as this data shows, if the pregnancy is viable, so if there is a heartbeat or not, what the gestation is, and what the ACG levels are, all of these seem to influence the effectiveness of systemic methotrexate. For the next 2 slides, I'm going to speak about suction evacuation and double balloon. I'm combining them because I'm looking at treatment complications. And actually, if you terminate the scar pregnancy with either of those methods before 8 weeks, the treatment complications were very low. But already after 8 weeks, and more so after 10 weeks, the numbers of complication, the incidence of complication increased. And we're looking for hemorrhage and development of AV malformation in this slide. So it's really clearly that the incidence of complication is dependent on the gestational age at termination. And also parallel to that is also the need of secondary treatment. So before 8 weeks, people did a suction evacuation or a double balloon, and it usually went well. But after 8 or even 10 weeks, people usually needed additional treatment. After 10 weeks, actually, in more than 50% of cases. So our data shows that there is clearly a global variation in care provision for CSP. And we believe that this uncertainty reflects the uncertainty of the doctors regarding the safety and efficacy of various management options. There are conflicting reports on safety and efficacy of the treatment options, and we feel that they are also likely to be due to confounders, such as if there is a positive heartbeat, what the gestational age is, what the ACG levels are, and eventually what type of CSP it is. So really, this is also a plea. We need your help. We want to develop a large registry study to develop prediction models for the outcome of various expectant and therapeutic management options so that we can counsel patients better in the future. Thank you very much. So if you are interested in collaborating, please register your interest on our website. There is also a registration form, or you can email us on our email, and that's here listed below. Thank you very much.
Thank you.
Thank you, Laura, and thank you, Andrea. That data should give everyone some food for thought. And while everyone's thinking about questions they want to ask, I'm going to ask a couple of questions. First to you, Laura. Presuming we're going to get an absolute tsunami of people who are interested to come and register with the website, what thresholds do these centers need to meet in order to be able to register? Do they have to have a certain number of cases or certain criteria?
Yes, so initially we didn't have any criteria, but now, yeah, we would like you to have managed 10 cases over the last 3 years until the end of the pregnancy.
Right. And I assume that all 10 cases, when you upload them, you will also have to upload an image for diagnostic validation. Is that correct?
Definitely. Yes, we ask a picture for each case.
Fantastic. Andrea?
A couple of questions about retrospective data. So I've managed 10 cases in my department over the last 2 years, and assuming I can get permission to upload these cases, are those allowed to be uploaded?
Yes. So you can upload your cases from 5 years back, because we would like to have like recent data. So
fantastic.
definitely.
Well, guys, I mean, this is a fantastic. Can I just say this is a fantastic initiative for uncommon conditions such as this one, and it's not that uncommon, but you know, for conditions such as this one, where there's so much variation around the globe as well in terms of treatments, as you have demonstrated so nicely, Andrea, we can only make progress if we all work together. So please, for those people who are enthusiastic enough to log on a Saturday, go through your data, have a look, see if you have cases. You will know them. You will know if you've managed the cases, because these are all the sort of cases that take a few millimeters off our coronaries every time we see them. Please do the world, the scientific world, and women the favor of sharing your data. There's no benefit in you knowing about complications that you've had and not sharing them with others. I'm sure many of us, I certainly, have had many complications and wish in retrospect I had done things a little bit differently for individual cases. Can you assure me, Andrea, that you're not going to come after me and tell me off for being a bad boy in managing a particular case?
No, absolutely not. I think it is really actually important to learn from the cases that potentially were difficult. These are the ones that we learn of the most, isn't it?
Thank you. Well, I already look forward to seeing you again next year with data, and we can set a date if you want to repeat this webinar. It's brilliant, really, really good. Passing over back over to you.
Just one more question for Andrea before we move on, because I think we've left the best to last as well. No insult to everyone else, but we don't want to keep them waiting so long. Andrea, just one question. Type 1, type 2. It seems really easy when we look at Judith's pictures to diagnose type 1, type 2. And that's, of course, in the VUM sheet in Amsterdam. That's fantastic. But we've now got pictures from 20 different centers globally all over the world. Do you think type 1, type 2 is really reproducible? Has anyone tested it? Has anyone validated it? Could we be getting it wrong? Could there be judgment calls?
So Davor wanted to.
Type 1 and type 2 in Judith classification is very different from type 1, type 2 in your registry. They're not the same. They're not referring to the same condition.
Okay. Is that right, Andrea?
So we are not dividing between type 2A and 2B. So for us, it's type 2 is in the niche and type 1 is on the scar. Yes.
Okay. We had that discussion earlier about gestation specificity and other confounders for type 1. So, but we will have that data, wouldn't we? Because at the end of this time, we can look at the influence of gestational age, beta HCG, residual myometrial thickness, because we've got that as well. So we can look at all of those factors and how they influence the outcome of pregnancy. You should be able to tell us by the end of the year. Is that right?
Absolutely. And also, I think it's good to have a discussion with Professor Jurkovic about the data as well. And I'm delighted to share it with him and have a discussion that brings scientific world ahead. So that's great.
Okay. Well, I mean, that's perfect timing now, because Davor, if you wouldn't mind, I think we should move on to your talk, if that's okay, unless Aris has got something else for us.
There are so many questions, and I don't know when to ask them. So, you know, there's questions around why are there these substantial differences in management around the world, and we're going to hear in the next 2 talks about 2 different approaches, which are both supremely logical approaches and also surgically successful approaches. And perhaps, like many things, these things come out of tradition, but I look forward to seeing the data. But the one thing that I will come back to is, when is it appropriate to expectantly manage CSP?
Okay. I think you're absolutely right. So we have 2 experts now who are going to talk to us. One is going to talk to us about what we're familiar with, surgical evacuation of the uterus and how that's applied. And then Ilan is going to talk about innovation and how he wants to treat things differently. But first of all, we have Davor, who I've known for over 25 years, we're giving away our ages now, who is Professor of Gynecology and Director of Gynecological Diagnostic and Outpatient Treatment at University College Hospital, one of the finest hospitals in the UK. He's absolutely an internationally recognized expert in gynecological and early pregnancy ultrasound. Davor, I'm really pleased you took time out to come and join us today. So whenever you're ready.
Thank you so much for this kind introduction. I'm delighted to be here today with friends and colleagues. And also I would like to thank all of you around the world for taking time from the weekend and the rest and listening to our lectures. I'm very grateful for that. My task for today is to discuss surgical treatment of cesarean scar pregnancy, with particular reference to what Baski said London experience. I'll just, for those of you who are not familiar with UK practice, in the UK we have something called early pregnancy units, and all women who have early pregnancy problems come to a defined place in hospital where they are assessed, scanned, and managed. And my unit, UCH, is one of the largest in the country. We see about 8,000 to 10,000 patient episodes, and also we are tertiary centers, so we attract referrals from all around the country. So our ability to collect material and expertise is very high. And in my practice so far, I managed around 350 scar pregnancies over a period of 20 years. And I'm going to tell you about my journey, how my thinking developed with scar pregnancy, how I came to conclusions about management which I have reached and which I'm using now. So the aim of my talk is to talk about indication for surgical evacuation, a little bit about technique, how to assess preoperative risks, talk about complications, and mention our long-term outcomes. As you have already heard, there are a lot of diagnostic criteria published in literature about scar pregnancy. They all differ slightly, and even top experts, as we have around the table, use different conditions to refer to the same terms in their diagnostic criteria. So there's quite a lot of confusion, and there is no uniformity or agreement, which is understandable because the reference standard, the diagnostic standard to tell us whether we're right or wrong, simply doesn't exist. In my opinion, scar pregnancy is defined by the lack of myometrium and lack of deciduum at the part of the uterus scarred by cesarean section. So to have a scar pregnancy, you need to have a scar which hasn't healed very well, and the defining characteristic of that scar is the lack of endometrium. And if pregnancy implants there, as we have heard before, quite rightly, majority will miscarry. But those who survive, in order to prosper, have to invade myometrium and embed deeper in the muscle. Therefore, inevitably, pregnancy is concluded, the risk of bleeding is increased, largely because pregnancies adhere to myometrium, but also there is lack of contractility at the cesarean section site. The other issue, which has not been discussed so much, is that when you look at cesarean section scar, it's not just lack of myometrium, there's a lack of mass, a lack of vascular architecture. In a normal uterus, there is a perfectly organized network which supplies pregnancy, which is developing, starting from uterine artery, arcuate, radial, and spiral arteries. In cesarean scar pregnancy, you're often going to see pregnancy which implants next to uterine artery, logically because there's lack of small blood vessels. And you can see this very small pregnancy, 7 weeks, that it tracks blood supply from the uterine artery. Uterine artery is dilated. I resent using the term AV malformation. This is nothing malformed here. This is just uterine artery responding to powerful vasodilatory stimulus from the pregnancy. And even this small pregnancy, you can see this massive branch of uterine artery coming into the placenta and supplying it. As a result of high pressure, placenta develops lacunae, and when this pregnancy is terminated, even if it's very early, the bleeding is going to be very significant. We also heard a lot of discussion about vocational scar pregnancy. Some people call pregnancy close to the scar pregnancy. Some people call pregnancy which is over the scar pregnancy, below the scar pregnancy. I would say this is a car crash. If something is very close to now the object, it's not necessarily a problem. And I would call this still parking, as I would call this case as well. Something which is very close to the defect is not a problem in itself. If something travels through a canal, it doesn't mean it's going to fall into it. This is a problem. And therefore, to have a true scar pregnancy, there is one most important defining characteristic. Pregnancy has to drop into the gap into myometrium. Anything else, I think, is clinically significant. There's a great danger that if we label these conditions as a potentially dangerous, we are going to terminate a lot of pregnancy, which are not even scar pregnancy, because of fear that something may go wrong. And I had experienced that before. Often people will refer patients, they will ask for advice, and I would say, this is not a scar pregnancy. Pregnancy posterior looks fine. I think we have to terminate anyway because the patient is terrified something will go wrong. So for those of us who advocate screening, you have to be very careful about ending up terminating pregnancy which are normal. And now I'm also slightly fearful that in the registry, these type 1 pregnancies are classified as scar pregnancy. In my books, they would be perfectly normal pregnancies. So there is quite a lot of confusion. And before embarking on screening, we have to be very careful that we agree what is right and what is wrong. In the UK, we've been studying this for quite some time, and our college, which is very quick to produce guidelines, has come with the criteria for scar pregnancy, which most people now use around the country. You could hear Amar referring to that as well. And the critical definition of scar pregnancy is the placenta is at the level anteriorly of internal loss, but it has to be degree of myometrial involvement, which is relatively easy to identify. Pregnancy which is going beyond at the medial-myometrial junction. I would say the other important feature, in my opinion, is lack of decidua. Normal pregnancy is surrounded by thick decidual layer. Scar pregnancy has no decidua. Decidua is somewhere else. And the blood flow is terribly important. And we had debates with Judith about value of blood flow. I don't think you can diagnose scar pregnancy unless you can use Doppler. If you can't use Doppler, then you shouldn't be trying to diagnose scar pregnancy because it's impossible to differentiate between true scar pregnancy and miscarriage unless Doppler is used to identify blood supply to gestational sac. This is my journey over the last 20 odd years with the scar pregnancy. I started, like most people, fearful of the condition, fearful of bleeding, systemic methotrexate, sit tight, and consider embolization if things go wrong. There's always one case that changes your management, and that was relatively early in my interest scar pregnancy. I had this woman who had 2 cesarean sections. She came for a scan because she had private obstetric care, and they wanted to know if pregnancy is healthy or not. It was a little dead pregnancy in the scar, 7 weeks. And I said, oh my God, this scar pregnancy, let's admit you. I'll give you standard Trexate, a couple of doses to bring HCG down. And then she went home and then she came back to casualty, bleeding heavily, once, twice, blood transfusion. I said, let's embolize you because it's getting really serious. So she embolized, she came back to casualty. And I said, this doesn't make sense anymore. Why don't you try to evacuate this pregnancy? So I did evacuate this pregnancy. I was quite scared. The evacuation was done under laparoscopic guidance. And when I took it out, I said, that was nothing. It was so easy to remove. Why did I spend a month torturing this woman with medication? Why did I spend a month doing blood transfusion? But I could have done it very easily. And from that moment on, I decided perhaps surgical treatment is a better option. I distended laparoscopy very quickly because there's no need to do laparoscopy if you use ultrasound in theater. I used Foley cutter at the beginning, as most people do. It's easy and it's accessible. I found it very hard to dispense methotrexate because everybody likes methotrexate. So I continued with local methotrexate for a while. I realized it's useless, doesn't make any difference, doesn't make the operation easier or reduces the blood flow. And then I dispensed with Foley catheter. I had the first case of sepsis and continuous bleeding afterwards. And I looked at the literature and I was thinking, what can I do to improve my surgical technique? But before I did that, I said, well, I will definitely stop methotrexate because using methotrexate makes no sense. Why not? Because it will kill the pregnancy. But the body, the dead person is going to stay in the scars. You're not going to be able to hide it. Pregnancy will stay there because there's no physiological mechanism to get rid of it. And because pregnancy attracts increasingly high blood supply increases with time. So something which is a relatively trivial problem to start with becomes a surgical nightmare because blood supply is probably the most powerful indicator of surgical risk when you're dealing with the early scar pregnancies. I have great respect for Judith, but I'm old school ultrasonographer, early pregnancy specialist. For me, hysterectomy is something I've never done, and I would never do hysterectomy for early pregnancy. And I respect my colleagues from the 60s in the UK. They used to do termination by hysterectomy, and then few people sat down and said, listen, this doesn't make sense. We're doing operations complex, which is dangerous to remove pregnancy. This has to stop. And it has stopped for good, and nobody does hysterectomy for early miscarriage in the UK, unless they want to visit GMC and explain why they're doing this procedure. So this is when I start thinking about alternatives to Foley and DNC. I thought hysterectomy is just out of my book. Hysteroscopic section doesn't make sense to me because if there is a bleeding and large pregnancy, you can't really operate hysteroscopically. There's thin meterm as well. You distend uterus with blood, so therefore you're making the whole procedure much more difficult. And when to treat pregnancy with mesothelial evacuation? Well, you should really look at those who have heavy and prolonged bleeding, and there is nothing else you can do about it because one is bleeding heavily. There's no methotrexate going to save you. You have to operate. Gestation has to be less than 70 weeks to transcervical evacuation. Beyond that, it becomes really difficult. Women has to be obviously keen on treatment and has to be fair conservative management. It is important to recognize that scar pregnancy can be accessible transcervically, but sometimes it is not. And that's the reason why this Ashley classification, which has been published very recently, we divide scar pregnancy as partial. The pregnancy is the contact in cervical canal and uterine cavity, and it can be removed using suctional curettage transcervically, or the pregnancy is complete within my metrium, and therefore there is no possibility to remove it surgically, and it has to be managed medically, or if it's very large, needs transabdominal approach. So the first question you have to ask yourself, if you're planning transcervical evacuation, can I access this pregnancy? These are examples of pregnancy which is adding my metrium, completing the broad ligament, and in these cases, you cannot evacuate pregnancy. If pregnancy is relatively small and it's alive, we can use methotrexate. I never use methotrexate for many reasons, but it makes women sick, while locally you can use very small dose of medication. You eject the embryo. It's quite an unpleasant procedure to watch, and you stop heart rate, and that's the end of it. The problem which we have with surgical evacuation is perceived risk of uterine perforation, because you are looking at the very thin endometrial layer covering pregnancy. You're looking at the risk of incomplete evacuation because it's quite hard to remove pregnancy tissue from an area which is irregular, and also women bleed, so you may end up leaving tissue behind, which could be a problem. And sometimes it's quite hard to enter the cavity and clean the decidua because pregnancy is in the way, and it's difficult to get past pregnancy into the cavity. Solution to all this is ultrasound guidance, and this is how you do it. We do pregnancy at the transabdominal, or if there's small transrectal guidance. Transrectal scan gives you the same quality of view as a vaginal scan. You can see an instrument in the cavity very easily. You remove this pregnancy under direct vision. You will not perforate because you can see anterior wall of the uterus. When evacuation is finished, you will see how front of the uterus, the wall is very, very thin. It moves with the suction, but because you're not going perpendicular to the wall, you're just aspirating it, it's not going to perforate. So risk of perforation, if you use simple suction, plastic curette, is not going to be a problem. I must say, I never use metal curette in early pregnancy, and therefore this instrument is potentially more dangerous. When it's finished, you're left with the problem. Pregnancy is removed, but you're left with a big cavity here, no myometrium, and bleeding. So how to stop this bleeding? This is something which is a second worry when you think about scar pregnancy evacuation, and it's quite a legitimate fear because some pregnancies are really very vascular and look quite unpleasant. So I tried folic acid first, as I did before. I didn't like it, as I had sepsis and incomplete success. And I found this paper from a group from Israel with Mashiach, who said we should use cervical suture to treat cervical pregnancy, and it seems to work in their hands. They had a few cases, and they said they had very good results. I said, well, that sounds logical. Why is it logical? Because if you use folic catheter, if you inflate it in the cervix, it causes a lot of pain and an incomplete occlusion. If you inflate it higher up, you're going to distend the uterus because there's very little myometrium around the cesarean scar pregnancy. So you can inflate this balloon as far as you like, which is contrary to common sense. You want uterus to be small rather than bigger. And secondly, this is very irregular area, often herniates towards the side of the broad ligament. So therefore, a balloon is not going to occlude effectively all blood vessels. If you use like a suture and you know a little bit of physics, you will know that the pressure in this area, if fluid is occluded, is going to be evenly distributed. So every blood vessel which is in any corner of the irregular sac is going to be effectively stopped. And this procedure I started using about 2003, and I never looked back. Why does it work? It works because you put Cesarean suture in the cervix, and you use uterotonics to create high-pressure environment in the cesarean section scar. Although there's no myometrium here, the pressure of blood is going to stop the bleeding. And if you look at the end of the procedure, you will see the scar, Cesarean suture in the cervix. There's a cavity with the blood. Looks quite dramatic, but these are small uteruses. You look at 15, 20 mils of blood at most. And it works magically because once you tie the Cesarean suture, bleeding simply stops. And which type of suture to use? Well, there are two possibilities, McDonald or Shirotka. Masha used Shirotka, I think he was right, because suture is smaller, is shorter. You can put it deeper, so it's less tissue between the suture and the Cesarean canal, so you can get a better closure force. Suture is inserted at the beginning of the procedure, it's not tight, and we use Mercelin tape, so we can use a lot of strength to close the cervix. And if there is no bleeding at the end, we simply remove the suture. If there is a bleeding, then we will tie the suture and remove it 2 days later under local anesthetic. And these are data we published a few years ago on 232 scar pregnancies. Majority of them were managed surgically. And what is quite important to say, I was glad to hear my colleagues talking about the registry. In 50%, there was nothing necessary apart from simple curettage. Early pregnancies, small pregnancies could be removed without need for any complicated procedure. Median blood loss was small, but in some cases it was up to 3 liters. And blood transfusion rates were respectively low, only 4.7%. Bearing in mind that a lot of our patients are coming from other hospitals after previous failed treatment, either medical or surgical, or because pregnancy is very advanced. So they're getting quite a skewed population of difficult cases. I'm going to refer briefly to the UK audit of scar pregnancy published a few years ago, which Amar has also mentioned. What we found, the technique I described is used quite widely in the UK these days. Success rate is very close to 100%, as opposed to medical treatment and expected management. We have success rates which are much, much lower. Complication rates were lower with surgery than anything else, and the residual tissue was a particular problem with the methotrexate. And again, data which I'm glad were confirmed by the registry. Methotrexate doesn't work. It doesn't work because if you use it, failure rate is very high, and you need the second treatment option afterwards. And this second treatment option is often more difficult because you already have tissue which is sitting there for weeks, which is vascular and quite difficult to manage. What is the risk of bleeding with surgical management? Cervical cerclage, where it depends on gestational age. It increases with mid-gestation, sac diameter, and cranial plant. But the most powerful predictor is vascularity. And if you look at the pregnancy on ultrasound, we use IOTA-modified score of assessing vascularity using color Doppler for 1 to 4. Even if pregnancy is very small, even if it's not alive, with this blood flow, you're going to face great difficulties. You're going to face great intraoperative blood loss. So vascularity, in my opinion, is the most powerful, most important indicator of risk, even bigger than gestational age. If you look at the live pregnancy, the data we collected recently, again, I'm glad that the registry works so well because we have shown very clearly, same as you did, that if pregnancy is less than 60 millimeters, less than 8 weeks, there's virtually no risk of excessive blood loss or blood transfusion. So these cases can be managed by somebody who's not particularly skilled but knows how to do DNC and remove the pregnancy, and the risk of bleeding is very low. When you go above that cutoff level, risk of transfusion increases progressively, and when you come to 10, 11 weeks, I think that these patients should be referred really to very few dedicated centers who can deal with the second trimester scar pregnancy, which requires surgical evacuation. What can go wrong? Well, you can have excessive blood loss, but again, having suture in place is an excellent insurance policy. Blood loss becomes excessive. You can tie the suture, stop procedure, resuscitate the patient, transfuse, and then come back a few days later to remove the rest of the pregnancy. If cervical suture is not working, which is very rarely the case, I had a couple of cases in the past, you can put another suture above the first one and you will stop the bleeding. I never needed to put a third one. There's another case which again changed my practice only a few years ago. This woman came. She was from north of England. She was 14 weeks pregnant, young woman, desperate to keep fertility, bleeding for several weeks. Pregnancy was 14 and a half weeks. The cervix was open. She had bled recurrently, and the placenta was only 1 centimeter from the external loss. In that case, I think the chance of this pregnancy progressing is virtually zero. And she opted for termination of pregnancy. When I look at her, my heart sank, not only because it was 14 weeks pregnancy, but because placenta was all full of lacunae, it was degenerating. But when you look at the side of the uterus, placenta was deriving blood supply directly from the uterine artery. We did successful evacuation of pregnancy with a very large blood loss, but after the operation, she complained of severe pain. And I took her back to theater and looked at her, and she was bleeding from the artery, large artery on the side of the uterus into uterine cavity. And we decided to take for embolization. The vessel was embolized, bleeding was stopped, and eventually she recovered. So from that day onwards, what we're doing, if we finish evacuating a large, very vascular pregnancy, we continue scanning women with the stitch in situ. If there's a pulsating large artery, we'll take them straight to our radiology colleagues, and they will embolize selectively only one blood vessels. Until now, in the last 20 years, I need to do 3 cases like that. But nevertheless, it's something which can help you if pressure of blood is so high that although suture is containing the blood, the pressure is causing severe pain, and eventually suture will give away. Can embolization help in other cases? Yes, it can. This is another example of a woman who came to us. She went for termination of pregnancy at 8 weeks. It was medical termination. It was failure, but failure was not diagnosed until 16 weeks. Then she presented massive blood loss during surgical termination. She had laparoscopy, and she continued to bleed. So she came to us, and what you could see is the cavity full of blood. If you look a little bit on the side, you will see massive blood vessel here on the right side, feeding the cavity. On the left side, small amount of retained products, which you can see by increased blood supply and hardly any tissue. And then if you look here, you can see this massive blood vessel feeding into the cavity. We embolized this patient rather than doing evacuation. Embolization was successful. Bleeding has stopped, and small amount of tissue resolved without need for intervention. So embolization was the only thing we needed in this particular case. Another example of a patient who had were referred to us. She had 2 previous attempts to remove scar pregnancy, total blood loss 3 liters, and this is what we found. She had a massive, large, dilated blood vessel on the right-hand side, perfusing small amount of pregnancy tissue. We decided to embolize her because putting suction keratin in this uterus would just suck masses of blood within seconds. Embolization was done, partially successful, but still very large amount of blood coming into the uterine cavity. So in that case, we decided to do something which we haven't done before. We did ultrasound-guided laparoscopy. We identified blood vessels. The surgeon was palpating with the instrument side of the uterus until he compressed the blood vessel which fed the pregnancy. We told them, here's the place. The suture was put in, and bleeding was stopped, and then we evacuated tissue in an avascular field. So sometimes in scar pregnancy, you have to be prepared to look for unusual solutions, but logic and common sense usually work. What is the risk of leaving tissue behind? Not very high. About 9% of our women had retained products after evacuation. I must say some of them were 12, 14, 15, 16 weeks after pregnancy, and only 4% require intervention. So most of the small amount of tissue will resolve spontaneously without need for further treatment. Is it worth doing it? Is it worth saving the uterus? What is going to be outcome in the future? Many years ago, we published the first paper by Jara Benagi showing that Risk of scar pregnancy recurrence is 5%. I've been collecting data for many years and they remain exactly the same level. My colleague Jackie Ross-Von-King, who does a lot of scar pregnancy, has the same rate. So I was quite surprised to see Timo Trich reporting 34% recurrence rate, which would be very worrying for me. But it just says that his results are based on meta-analysis, that when we say scar pregnancy, we don't all think the same. And I think a lot of scar pregnancies which are classified in this meta-analysis as being problematic, I would probably not call scar pregnancies myself. Just to summarize my talk, this is the management protocol we use in our hospital for many, many years. Hasn't changed because it works. I'm still here, have no medical legal cases, and none of my patients died. There was one hysterectomy out of 350 cases. So if cesarean section scar is complete, we will manage local methotrexate below 10 weeks. If it's bigger than that, it's actually an abdominal pregnancy, a pregnancy in the broad ligament. So if you want to tackle it, you have to treat it as you would treat any abdominal pregnancy. If it's a partial, we'll consider surgery. If pregnancy is small, or if it's failed, but it's avascular, usually simple evacuation without any additional procedures enough, often in outpatient setting using MVA. If pregnancy is larger and it's vascular, we do the evacuation with Shiroka suture. As I said before, in very large pregnancy, we have also embolization on standby in case of leaking artery into the uterine cavity. More than 70 weeks, we haven't tackled yet. I think we need to think about that, but at the moment we say it's too late. I have no confidence I can save a uterus. Good luck, and hopefully you have a baby and uterus at the end, although this is not the most likely outcome. So when not to operate a scar pregnancy, well, women do not want to have operation, when you can't access pregnancy tests vaginally, when you have retained products which are very small, if you're not sure about diagnosis, or if there is a lack of expertise in ultrasound-guided procedures. You shouldn't be doing it unless you know how to use ultrasound in theater. Why to evacuate scar pregnancy? Well, it's effective. It gives you fast recovery. Risk complication is generally low, and fertility is preserved. Thank you for listening.
Gabor, excellent. You didn't let us down as usual. So thank you for going through that and presenting a very didactic talk and a very clear vision, and your strong feelings come across really, really very palpably. Can I just clarify some things, because I may have missed it, and surgical evacuation everyone's very familiar with and very comfortable with because they do that in their daily practice. But there are clear differences in what you do, right? Because first of all, you are conducting, I've seen you scan. Yes, you're not your average gynecological scanner. You are conducting an ultrasound-guided evacuation, correct?
Yes.
Okay, and the second thing is, it wasn't clear to me, but were you putting just one suture or were you putting two sutures, one below and one above?
Now, I'll always put one suture, and in vast majority of cases, this is enough. Only if suture is not achieving complete occlusion, if blood is coming to the cervix, I will occasionally put another suture. But again, in the last 20 years, there were only 2 occasions when I put 2 sutures. So it's very, very rare. I was just trying to explain what to do if you have a problem. If you're stuck and the suture is in place and it's bleeding. But normally it's in most cases.
Lovely. You gave a very, let's give one more question, Aris, and then you can open it to the floor. Right. You gave a very clear, I'm so used to you. You give a very clear didactic message, below 8 weeks, it's okay. Above 8 weeks to 16 weeks, you need a real surgical expertise, etc. And I think that's absolutely right. But here's my problem. What if it's 7 weeks, but it's a type 4 vascularity? It's hugely vascular. Are we still okay to do just a surgical evacuation? Or what if it's 9 weeks and there's absolutely no vascularity? Would it not still be okay? Have you got that computer model in your brain to tell you which is okay and which is not? And is that easily transferable to another unit?
When you talk about weeks, you have to be very careful.
CRL.
Week means one thing in live pregnancy, another thing in pregnancy which is not alive. And in early pregnancy, pregnancies which are alive tend to be easier to manage. Their vascularity tend to be less.
All alive.
Compared to miscarriages, tend to be vascular. So actually, pregnancy is going to give you a headache. In early first few weeks are those which are failing and look very vascular. Yes, there are always exceptions to the rule. So you shouldn't just run into a procedure. And I said, the main factor apart from gestational age is vascularity. This data I collected a few years ago, and I show you one case of 7 weeks pregnancy, which actually was very problematic. So if you're planning to do evacuation, if it's a live pregnancy, if it's less than 8 weeks, and if it's not very vascular, I think you can do it. And majority of them happen not to be. But
what if it's less than 8 weeks, but it's very vascular?
In that case, I would suggest that you either use the cervical suture or to send somebody else, yes.
Okay, so you think vascularity is more important than 8 weeks in an ongoing pregnancy?
At any stage. I had pregnancy 12 weeks, which I removed without any blood loss.
So that algorithm you presented at the end, we must qualify it. It's trumped by vascularity.
Yes. I mean, I didn't, because when you look at lacuna as a part of the study, you will see they also contribute to blood loss. But I just try to simplify things for the lecture. There's always every problem, of course.
Okay. Aris, do you have anything from the global?
Davor, I have a couple of sort of general questions. There's a lot of talk of methotrexate, people putting slides up very quickly on methotrexate. Are we talking here about systemic methotrexate, or are people talking about local injection of methotrexate? And what are the pros and cons or differences between the two?
It depends on the expertise. You know, it's if you're running early pregnancy and you're an expert, you should be able to do a local injection of pregnancy. And I learned that because Timur was first to say if you manage cervical pregnancy, you should inject local methotrexate. And he was right. Why local methotrexate? Because you give 25 milligrams methotrexate, which I think is actually too many. You can give 5 or 10; it's enough. And with systemic methotrexate, I had women having a problem with the liver function. Had women who was paralyzed after systemic methotrexate, couldn't walk for a month. I thought I'm finished in my medical practice. With local injections, I never had a problem because women are absolutely fine. There's no effect on the blood results, and it always works. But systemic methotrexate, particularly if you have live pregnancy, is touch and go. So I stopped systemic methotrexate 20 years ago and never looked back.
And then a couple more technical questions. So you put this suture in, and Tommaso Binardi is asking from Italy, but does this not act like is it not just plugging the cervix? Do you not just cause a hematometra behind it and you just don't see the bleeding? How does this help?
But that's the desired effect. The desired effect is to cause hematometra, which exert compression on the uterine vessels and stop the bleeding. You use bleeding in the cavity as a means of stopping the bleeding. So you're not occluding cervical artery, uterine artery. No. You're tamponating.
You're using the bleeding as a type of tamponade in a way, instead of a balloon, which would not get into that cavity because it's of irregular shape, etc.
But also, you take if you have a uterus without myometrium, if you try to inflate the balloon, you can inflate it as much as you like because there's no resistance there. So using balloon, I always found slightly logical because I always thought I want uterus to contract, I want uterus to be smaller, I don't want uterus to.
Davor, I'm going to go on to Ilan now, but I want you to think about something. If blood is causing tamponade to stop bleeding, why can't the balloon also do the same thing? But don't answer that now. We're going to come back to that in a second. Okay, so I know that
Prashant has one question.
Because you are saying that the suture, McDonald's or Shirodkar, can we use now? There are a lot many cervical caps which are available to prevent the preterm birth. Can we put it just cap on the cervical? It will work exactly the same without making any intervention with the Marcellin tape or any local intervention. This is without any intervention. You are just plugging the cervical canal. That's what we need.
Like the Arab in Cesarean.
Right there without this.
It's a good suggestion. It's something which is perhaps worth trying, and I haven't used cap before. When I find something which works, I don't change it very easily. But now you mentioned it, it's worth looking at this because the only question for me is cervical carbohydrate strong enough to contain the blood in the uterine cavity? That's all. But yeah, I think it's a good alternative.
Yeah, we have one of the good picture on our UOG journal before a couple of months where they were showing a cervical pessary, which I think one of the Israel company has formulated one this kind of cervical cup, which has got 3 or 4 different connections on the cervix. You have to plug in 1, 2, 3, 4, and it's going to block from all 4 or 5 edges. So that's what we need. And without any intervention, we can put it. We can put it for 4 hours, 6 hours, and then we can remove it. So without any hesitation, we can do it as and we want.
There you are. Live innovation, global innovation in one, from India to London via Croatia. We're sorting this out slowly. Ilan, I don't want to keep you waiting anymore. I know that you've been up early. So in order to provide contrast, we have Ilan next, who's going to talk about when and how to do double balloon therapy. Ilan is Professor of Obstetrics and Gynecology at NYU School of Medicine and also scientific editor of the Journal of Ultrasound Medicine. He is well known to most of you and doesn't really need an announcement, but he's a well-respected expert in the field of Cesarean scar pregnancy and morbidly adherent placenta. Thank you, Ilan, so much for making the time to come and talk.
Okay. Do you hear now?
Absolutely, yes.
Perfect.
Okay. So I will talk only about one single aspect of treatment. And again, I'm feeling frustration because I couldn't say anything about the other management kinds of management. So let me give some credits. I'm really standing on the shoulders of my peers who really taught me all what I know about cesarean scar pregnancies. They started early in the late 1990s and the early 2000s. And standing out of these were Ivan Vial in Switzerland, Davor Jurkovic in the UK, whom I know from his Croatian connection, probably many more years that I care to because it was old times, and Chrissy Comstock in the USA, whom I learned from a lot. Notwithstanding other scores of other clinicians, the names would take too long to mention here, they care to publish their observations leading to at least 2,647 posted articles of today. And if I also put in cesarean scar ectopics, there are another 700. I will be mentioning only the management of scar pregnancy, but more specifically, one of them that I frequently, but very clearly not exclusively use. So here are the management, and they can be classified as one of the following: major surgery, and we have heard about some of them, and you can read them right here. Different kinds of surgeries, dilatations, aspirations, laparoscopy, minimally invasive treatment that go without general anesthesia, local injection, then systemic, single, multi-dose, IM, or even intravenous methotrexate, uterine artery embolization, done predominantly as first treatment or combined with others, and then combination of all the above treatments. Then there are the local pressure by inflatable balloons, single Foley, double cervical rifling. My favorite to go to like a general review of the treatments are these by Maleux-Lacroix. She really showed us all the successes and all the perils of it. Our Foley balloon catheter was published after this article, therefore are not included here. So let's all ask, are there guidelines? And it's obvious that none of the countries, including the United States, have a set of guidelines at hand when a patient with an earlier ACRITA or a cesarean scar pregnancy presents. That's why we need an international registry. So let me talk about treatments that are based upon pressure effects. And again, I'm talking about the single and the double balloons. The single balloons were published by us in 2015. And basically it was like place a single balloon as a single treatment or inject local and place a balloon afterwards. And basically, it is based upon this pressure that is put on the scar pregnancy or a cervical pregnancy for that matter. It's several millimeters more south of this one. And then look at the picture and evaluate its efficiency. The story of how this came about is that we published 18 cases, and they were done prophylactically as an adjuvant to the treatment. And we thought that controlling balloon inflation by transvaginal and or transabdominal guidance is easy to perform. It can alleviate severe bleeding, render other more involved risky surgical interventions redundant, or at least add to them. We suggested making the Foley catheter readily available when local, minimally invasive or other treatments are undertaken. However, the balloon slid out spontaneously after 2 days in 2 patients and in that series. And after 5 days in another patient, that was a patient who was treated across a holiday, and I had no access to the patient. It was probably caused by uterine or cervical contractions. The uterus doesn't really like too many stuff. That's our luck, because at least spontaneous abortions are expelled also. The idea of using the double balloon, inflating the upper balloon within the cavity to serve as a retaining, or as I say, an anchor balloon during inflation, basically appears logical to us and was tested. So here is the article, and again, so it's simultaneous termination and bleeding prevention, simplifies treatment, minimizes patient discomfort, and we adapt the catheter familiar to the OB in the labor and delivery to treat cervical pregnancy and scar pregnancy. But this is here where I made a misassumption. I realized that not too many places and the places that deliver patients use the cervical ripening balloon. I will talk about that later a little bit. It is high success rate and low complication rate, and the rare complication is really an AVM, extreme myometrial vascularity. Davor talked about it beautifully. That is usually treated by UAE. And Davor, I will try your ligation of that artery that feeds that area. So basically, here I summarize, first of all, the single balloon that you see there inflated and putting pressure, and then the anchor balloon inflation and the inflation of the treatment balloon in our cases. Both have high success, low bleeding, low hysterectomy. And that's the general picture of it. I don't want to come back to. So let's see how it's done live. Here is the tray that I use. And I leave it on to let you see, but you can later access it. I use a curved tenaculum. That's one of my main instruments. I also use a single hinged speculum because I can extract the speculum without manipulating the catheter through its opening. Then I use Hagars in not too many situations. I will talk about that also, and the needle for paracervical block, and of course lidocaine. So here is basically what I do. I do pain management 2 hours before and then every 6 hours, reducing pain due to balloon distension. Now, this is extremely important. When you have a patient with a prior vaginal delivery or DNC, that makes the catheter insertion easier. Without the above, some cervical dilatation may be needed using the paracervical block to accommodate the diameter of the catheter. And to reduce this diameter, I usually use small syringes to aspirate air, collapsing the balloons through the red and the green ports. And after I did that, here is what they look. So they are a little bit less voluminous, and I can push them in easily. So what do? I hold the anterior cervical lip with the curved tenaculum to enable to push the catheter in the cavity. These are my primitive ways to show it. I position the catheter into the cervical external os and then push the catheter into the uterine cavity using a ring forceps guided by a transabdominal ultrasound. Here is where I use transabdominal ultrasound. So this is what's happening. You see the scar pregnancy, the vascularity, the catheter in the cavity, the anchor balloon, compressed gestational sac between the both inflated balloons, and then deflate the lower balloon. I talk about this later. And if you at times want to use it in a lower scar pregnancy or even a cervical pregnancy, I inflate one of the balloons opposite the scar pregnancy and the second one in the vagina. Now watch it live, and this I got from Dr. Marcos Cordova from Michigan, who was one of our MFM fellows. So here it goes. This is the introduction of the catheter under transabdominal guidance. Then I inflate the upper anchor balloon also under transabdominal guidance. Make sure that the bladder is sufficiently full in order to fully see, beautifully see this process. Then I take out the speculum, and on the transvaginal ultrasound, I inflate the lower balloon and assess the size of the upper and lower balloon to see whether I need to top up either of them. Then later on, and I will talk about that later, we deflate the balloon and remove the catheter. So we adjust also the size of the balloons, the lower one, as you see here. Watch live how it compresses the pregnancy. This pregnancy, by the way, was pretty dislodged upwards. And then I topped up the upper one in order to really achieve the complete collapse of it. Serum HCG is expected to recede in 2-3 weeks. That's nothing new. We use it in the cervical pregnancy, and you can see here all the stages that I showed you previously with the scar pregnancy. There is nothing new about it. I use also sometimes a 3D to see whether I really place the balloon in the regular place, but that's not really that much necessary. So what are the lessons that we learned under this? After publishing the first article, we received emails, telephone calls, text messages regarding the technique and patient follow-up. Then we published a follow-up article with tips to improve the technique. This is the article, and it was published, I think, a year later or so. So here are the ones that I already showed you, and I mentioned these previously. But here are some other tips that are in this article. Catheter dwelling time. Everybody asks you, how long do you keep it in place? So here is a little story. I thought that I would want to keep the catheter in less and less and less and less. And again, the 3 days is usually over the weekend. I do put in the catheter Friday and then go back and remove it Monday. But I thought that it may be important to do it earlier and earlier. And I think that the ones that I really removed almost the same day, put the back catheter in and then see no heartbeats and take it out in the evening, I think that these were the ones that developed some more vascularity. So I want to really compress the area of the blood supply, and now I leave it in for 3 days. I administer oral antibiotics. I call the patient every day. Here in the States, I do it. You know, lawsuits here, lawsuits there. That's a very good practice. If it was a referral, call the MD with a report. Be nice to him to get more patients. Catheter removal, see this slide. If there are no heartbeats or no recent bleeding, deflate the lower balloon, wait about an hour, then go back after an hour, deflate the upper balloon, wait another 1 hour. Now, if no bleeding is seen, slowly, gently pull out the catheter. Seat the patient in the waiting room until you write the report. If it is not bleeding, then give instructions to her. You rescan in several days and check the HCG. Now comes something pretty important. Please pay attention. Give the patient a discharge report describing the procedure, because if she has to go for some pain, bleeding to a different emergency department, they probably never heard of this entity and this treatment. I advise against surgical removal of the tissue remnants at this point. It may cause severe bleeding, opening up, definitely not a sharp curating. Davor mentioned that very nicely. Wait for serum HCG and vascularity to reach their minimum, and again, consider in this point expectant management. Lastly, the catheter comes in two versions. We suggest the one with the stylet because it provides sturdiness after shaping it to match the curving cervical canal, contributing to an easier insertion. And then be patient, spotting, bleeding. It lasts for 2-3 weeks. Hold the patient's hand on this. And that is due to retained products of the scar pregnancy. So further experience. There are no articles in the literature that attest to quite a lot of cases. I don't exactly know what's happening, maybe 60. Unpublished, maybe another 20, 30. Don't hold me for this slide. Now I'm looking what my friends do. Palermo, Cali in Italy, 6 to 7 weeks, double cervical ripening catheter. Later on, he does intergestational injection and the balloon. After 11 weeks, he also use embolization and so forth. My friend Francesco D'Antonio in Italy, before 80 weeks, double balloons. After eight weeks, massive vascularization. Again, as Davor correctly pointed out, then he uses methotrexate and uterine Albany embolization. So what are the usual reasons not to use the double balloon? Rightfully or not, every clinician uses the treatment he and she is accustomed or feels comfortable with. Old habits die hard. Not too many people want to change their practice. So look at the excuses and see my answers, because I have an answer for almost everything. Not familiar with the technique. My suggestion, read about it. It's the first step. If your OB uses it in the labor and delivery, watch it being inserted. Or call Timor, here is my number, usually during my daytime. I never heard about it. My suggestion, try the website. Here is an article for it, and read our article that was pretty clear, and also the follow-up article. Or call Timor, 917-520-17177, any New York daytime. I don't work in the labor and delivery. I'm not exposed to its use. We do not ripen the cervix. My suggestion is there is a review that you could read, and here is the review that you can really go to and see how the double balloon is used for cervical ripening. Again, you can call me anytime. We do not perform this in the ultrasound units. I'm worried to use it as an outpatient. Well, my suggestion here is do it in the OR, paracervical block, experience how simple it is. In the ultrasound suite, the sonographer can help operating the machine. We do it only in the ultrasound suite. If you have a resident or a medical student, use their help. If you have a daycare facility, use it to watch or hospitalized over one night, and then maybe later you can use it as a one-day procedure. Or again, call me but during the daytime, please. I will wait until the different societies will be endorsing this procedure. I have a warning for you in this case. Do not wait for this to happen anytime soon. If you wait, you man, you will grow a long and funny beard by that time. And you ladies, you will grow a very, very long hair. And then there is one, I don't like Timur. He's obnoxious, talking about balloons. He insists that scalp pregnancy is not an ectopic. My suggestion is, I forgive you. You are entitled to hate. Try to overcome your negative feeling by thinking of the simplicity of the procedure and the advantage for the patients based upon the mounting evidence. And if still not an ectopic pregnancy. And be courageous, call Timur at any daytime or wake him up at night, sharing your true feelings about him and his balloons. So basically, here are all these excuses. All of these seem to be surmountable, and I think that you can do that. Now, here is my treatment procedure. If there is a heartbeat, then I'll go on the other side in a second. If it's negative, recheck at 3 days. If no fetal heart, after 3 scans, or 7 weeks by reliable dating, you follow up by ultrasound, by HCG until it's 0. Now, if there is heartbeat, counsel based on evidence. If the patient requests the TOP, select an appropriate treatment to stop the heart activity without delay. Start immediately. And I start with intramuscular methotrexate. Determine the gestational age. Before 8 weeks, double balloons or local injections. Past 8 weeks, local injection, question mark embolization, and really past very much over 8 weeks and no fertility, desired gravid hysterectomy. In the 2 first cases, as needed weekly HCG and ultrasound, watch for possible enhanced myometrial vascularity, beautifully shown by Davor. If the patient is interested in continuing the pregnancy, counsel for possible placenta accreta spectrum. Determine if placenta in the gestational sac is on the scar or in the niche. Measure the myometrial thickness and see whether it's bulging into the bladder or not. Use the article that Andrea wrote, and that will talk about the thickness of the myometrial layer. If it's less than 4 millimeter, it is high risk for increta, percreta, and cesarean hysterectomy. If it is on the scar, not on in the niche, or type 1, or it's more than 5 millimeter, it's low risk for PAS and cesarean hysterectomy. So, summary of my lecture. CSP is a dangerous, life-threatening baby placenta accreta. 2, no uniform diagnosis and treatment protocols are available. If termination of the pregnancy with a positive heartbeat patient is desired, do it without delay. The dual action of the cesarean right-planning balloon is effective and simple to use. It can also treat cervical pregnancies. Its use could be or should be, I don't know, integrated into a comprehensive treatment algorithm as one of the possibilities. What we do, and we also discussed whether we, I think that Amar discussed this, whether we should screen for it. And I have a lot of comments on those 3-4 slides, but we give our patients who are discharged from the hospital after a cesarean delivery this little brochure that asks them to please come and get scanned if they get pregnant after a cesarean delivery. I think that that is logical, And yes, we have to determine its usefulness. There are 2 articles now talking about it, one by our Italian group and another one by the Nicolaides group. And again, international registry was created. We encourage to upload these cases. And as I always say, just do it. Thank you very much for your attention. And if your language is not up here, email me and I'll put it on. Thank you.
Thank you, Ilan. Thank you so much for a fantastic presentation. There are many questions, and your phone number, I fear, may be used given the number of questions that are coming, but I can assure you that only the messages are of love. There is not one single of hate. Baski, I'm going to let you maybe lead the discussion and try to pull together some of the issues that we have been discussing today. And I do have some questions that I want to get through as well, but please go ahead.
Okay, so thank you. Thank you, Ilan, again. Yeah, I'm very worried about your phone number, but let's hope you get to family and friends between calls. So you described a series. Now, I appreciate that you've been doing this for a shorter period of time than surgical evacuation, which has been going on for 20 years, etc. So the numbers are a little bit smaller. Do you have any feel for the influence of gestational age and vascularity on the success or failure or the complication rates for double balloon treatment? Because, you know, Davo was very clear about the impact of gestation and vascularity. Do you have a feel for that, or?
Yes, I definitely do. First of all, I have to mention I think it was almost the last slides of Judith that said the gestational age. I wanted to ask her whether in these cases that she showed in that slide, whether the gestational age played any I would say reason to apply the 1, 2, or the 3. I liked that slide. And I think that if I would have some information from her later on to see in which case is applied which one. And then Davor also talked about the gestational age. Extremely important. I think that, and here I justify also my line in my slide, which says, and I changed my slide, that I want to do it without delay. And I took out 2 lines, and the 2 lines were the following. I put pressure on the patient to give me an answer. And I explained the patient is not because I want to do the procedure, it is because every single day the vascularity increases, the penetration of the placental villi into myometrium increase. Therefore, the procedure to terminate the pregnancy, if that's desired, is more complicated, and the complications are increasing. So I have an objective reason to say that, yes, gestational age makes a big, big difference. And I also criticize our generalists who may see this patient after a cesarean delivery, and they say, oh, come back at around maybe 8 or 9 weeks. At 8 or 9 weeks, that sac is in the cavity and the little fetus is gravitating into the cavity, but the placenta stays anchored in the place. So that determines the diagnosis, not the location of the sac pregnancy. And here is where all the mistakes are made. And I think that most of the people talking with me agree to this one.
That's fantastic. So the key question is, from a diagnostic perspective, there seems to be some degree of consensus that the niche task force has produced criteria for diagnosing uterine niches. There seems to be some consensus with variability about 2A, 2B about typing the pregnancy. But there doesn't, to my mind, there doesn't seem to be a consensus about the effect of gestational age on the type, and there doesn't seem to be absolute consensus about vascularity. Am I correct in that, Judith and Dabo?
Yes, I mean, the classification can be useful for determining the treatment, but that's not the only indicator for treatment. I think gestational age and vascularity.
Let's stay off that, but we haven't included. So here you are, you have two experts telling us that gestation makes a big difference to the success and failure. You have two experts telling us do different things, that vascularity makes a difference. And yet we have a diagnostic criteria for CSP that does not include gestational age, that does not include vascularity. How is that adequate? Should we not include it? Dabo wants to answer for you.
The problem with consensus versus science is that it's based on opinion people around the table. And I was part of this process. And there's a concern I raised myself. I appreciate Judith. She thinks like a surgeon. If fibroid is 50% of the cavity, we'll take it out. If it's 50%, what? But logically, having this division in the type 1, type 2 makes no sense, because something what is type 1 at 7 weeks is going to be, or type 2 at 7 weeks is going to be type 1 at 12 weeks. So I must say I was opposed to it, but it's a consensus. So we all signed to the majority view to how democracy works. But I think I agree with Ilan. I think and your thoughts that this is not really helpful. I don't think it makes a big difference, but that's what we concluded. There was clarity, again, was a contentious part of our discussions, Delphi procedures, because a lot of people thought Doppler is not important. I think it's essential, and we came to some compromise at the end to say, well, we can use it. But yeah,
I would like to comment on this, because the classification is only meant to talk to speak the same language, the same as we have for submucosal fibroids. It is a type 1 or type 2. It's only indicating its location and its relation to the uterine cavity. And it doesn't say anything about the severity, because you can have different sizes, different vascularity. It's only mentioned this paper to discuss about the location so that we all talk the same language, because some are talking on the scar, in the scar. That's all kind of subjective. So that was the only intention, to have a classification on its location.
But Judith, I get that. So at least we're making progress. It's not a criticism that it's not required. What I'm saying is that we need to go further, right? We need to define the influence of gestation, define the influence of vascularity. So now we're going to come.
There's a difference. Yeah, I think the difference, in my view, Baski, that you're describing, is a difference about classification or nomenclature and staging. There's a difference between a stage 1 cancer and a stage 2 cancer and a stage 3 cancer, which is a progressively worse condition. And there is a completely different thing, which when it comes to nomenclature, which is, as Judith says, a submucous fibroid or a subserous fibroid. There are two different entities, but there's not that one is worse than the other in that, or a progressive.
That's exactly the point I'm trying to make. So the issue now is the whole idea of making a diagnosis is that we want to then go on and make a prognosis. And the question that keeps coming up on my board here is, why is there differences? Yes, 50% of pregnancies in Europe continue, whereas 80 to 85% are terminated in the US. And these differences are, can we have confidence, Amar, from the literature that exists, or Ilan even, can we have confidence that the literature is pretty robust in telling you what the risk of placenta accretor is? Or are these differences explained by the fact that there's huge variability in the existing data from small series? Amar?
Well, I can relate to the United States part of it, because basically here the flag is out in every office. It says patient autonomy. So, and you have to inform the patient. And when the moment you inform the patient and say, listen, this can end up bad, then they ask,
how bad? What's the risk? What's the risk?
Yeah, exactly. That they ask me what's the risk of it, And I honestly don't have a risk to give them.
That's what I want to know. That's
why we have the registry.
Fantastic. So we can make a diagnosis. There are limitations to the diagnosis. We all agree that we don't have good prognostic criteria, yet we're asking mothers to make decisions about whether they continue the pregnancy or kill their baby. Quite frankly, that's what we're doing. Yes, we're giving them Hobson's choice. We don't have any information, but you can get rid of your pregnancy and have big risks, or you can continue your pregnancy, and in some hospitals, hysterectomy at birth. In others, they get the choice of myometrial excision. Is it not that we now need better prognostic criteria? Do we not need to know that better? And we can only know that better once you have more than type 1, type 2. Once we start involving Doppler, gestational age, residual medical thickness.
Yeah, but Ilan, type 1 or type 2 is only mentioned to talk the same language. So it's only mentioned the location, and all the other diagnostic criteria should be added in the registry. But if we not agree on the location, I mean, this is why this Delphi procedure was started as step 1. Just have the nomenclature, so to be sure what the location is, and step 2 is the registry to add all the other criteria. And what I really would like to add to the registry as well is that we have information about future pregnancies, because now we only focus on the current pregnancy and how long does the patient stay, how long is the follow-up, how long does she have symptoms, but it's even more important, what's the time to the next pregnancy and what are the pregnancy outcomes?
Okay. Dabo, you wanted to say something?
One more comment before I give up. I think that you are only partially true whether you say that we don't have any indication. There is indication. And again, that article that Andrea was in and myself all on our thing here in my department, that 2 millimeter really made the difference between outcome. We quote this to the patient. I have no other things to quote at this point. And is it true or not? Will it be confirmed by a large number? Okay, I don't know. But at this point, that's what I hang on when I talk to the patient. I don't know what you guys do.
What do you say when you counsel?
Yeah, I just like to say that there are 3 outcomes of scar pregnancy, which is alive and potentially can continue. One is baby and the uterus. One is baby, no uterus, and no uterus and no baby. And no uterus and no baby is the worst outcome. I think we can reasonably well predict those, because what is very important when you look at scar pregnancy, which is alive, is symptomatic or not, and where is pregnancy relation to the cervix. A lot of pregnancy I show you today, even at 12, 14 weeks, open the cervical canal. If pregnancy at 12 weeks is 1 centimeter from external os, you can be fairly certain this woman is going to end up with no uterus and no baby. So I think these extreme cases, we can actually predict with reasonable accuracy. What is difficult with pregnancies in the uterine cavity, what's going to happen? I tell these women, you are very likely to go to term, but whether you have hysterectomy or not, it's very hard to say. And also just one more point before I shut up. When you look at scar pregnancy from the beginning, you cannot anticipate how placenta is going to develop in the future, because there are some scar pregnancies look terrible at 7 weeks. When you look at them at 18, 20 weeks, they look fine, because placenta in the scar degenerates and the rest of placenta exons. So you have to be very careful with the screening until we fully understand natural history. I think it's very hard to engage in screening at terminate pregnancies because we don't actually know who could do very well.
Okay, Aris, can I round up, do you think?
Yeah, I've got a couple more things.
Okay.
Because we ended with C-section pregnancy, but I'm keen to start back at the beginning very briefly, and with this whole question of niche, and actually even before then, prevention is better than cure. Judith, Paul Coleman from Indonesia asks, well, how can we prevent it in the first place? You're a surgeon. What do you think we're doing wrong at the time of cesarean section that is causing these problems in the first place? And do you have any tips that we can prevent that from happening?
I think the most important thing is to make the incision of the uterotomy at the right place, not too low. If the incision is too low, we see more niches. We performed just a randomized controlled trial in more than 2,000 patients, and we didn't find any difference between 2-layer and single-layer suture. So it's not suturing the double or single layer doesn't make any difference. But what made the difference is if the resident was the first surgeon or the gynecologist. If the resident was the first surgeon, we see more niches. So apparently, proper approximation, perpendicular insertion of the needle is very important. Other factors are that may of influence is, of course, also patients' factors, but we don't know that yet. But some studies show that preeclampsia may be an indicator for more niches. But I think the most important thing is the level of the incision.
Thank you, Judith. That's really very helpful. And that suggests then that emergency cesarean sections, perhaps in the second stage in particular, may be the ones that are particularly...
They have a higher prevalence.
You end up doing an incision actually on the cervix quite often. That very, very helpful. Ilan, please.
Okay, so it's little known. I have in my department one of the obstetricians who has under his belt more than 700 cesarean scar pregnant, 700 cesarean deliveries, and he is doing a very special kind of closure of the scar, of the incision. He leaves out the endometrium and closes it, and he calls it endometrium-free closure. He published this about maybe 5 months ago, and you can read it in the literature. His name is Antoine, Clarel Antoine. And in his 700 plus cases, believe it or not, hard to believe, there is no cesarean scar pregnancies in his series. Now, he accounts for some that did not that were not sectioned repeatedly or left his count, but he went after these by phone, by car, by email, by everything, and there were no scar pregnancies. So this is one way that may, if he proves his point, maybe we should change our closure technique. Baski is like wiping his head. I don't know what he says. Cannot be true. Cannot be true.
There is one randomized control trial that compared endometrial sparing without endometrial saving technique, and there were more niches in the endometrial saving technique, probably due to superficial suturing. So I don't think it is endometrial saving, yes or not, but it is probably the good approximation, good suturing technique of the surgeon itself is more important than if you save the endometrium, yes or not. But that's what's from the literature so far.
Judith, Prashant, I'm going to come to you, but I just wanted to stay with this theme of prevention. So you talked about, you talked, Judith, about trying to prevent it at the time of cesarean section. The second step, I guess, a secondary prevention, I guess, is you've seen a niche in a woman who is not pregnant. A woman you have seen, she has a niche in the pregnancy, in the uterus, and she's planning to get pregnant. The pregnancy can implant itself anywhere it wants. What is the risk in that woman with a niche that she ends up with a niche scar pregnancy? Do we know that?
No. We are following up now all patients that enter our clinic with a niche. And so far this year, we started it and we have 400 patients in it and we follow them up all. So probably within a few years, we know the prevalence of cesarean scar pregnancies. But so far, it's not that high. But I think it's to the larger the niche, the higher the risk.
So then I have a question here from Maria Izquierdo from Spain. She says, okay, so after all of this discussion, I see a woman, incidentally, I do a gynae scan, I see a niche, she's planning a pregnancy. Do I operate on her to do a potentially difficult procedure and close this niche? Do I leave it alone? And because actually the risk of a cesarean scar pregnancy overall is quite low, what is the current understanding?
Well, we advise them just expective management, but we advise them to come in an early stage for an ultrasound scan.
Eric, the answer is quite easy. Eric, the answer is quite easy. There's an answer. There's an answer to that. You asked the question. The answer is very, very simple. If you look, 1 in 4 women who've had a cesarean section will have a niche, roughly speaking. and about 4 or 5 in 1,000 women who've had previous cesarean sections will have placenta accreta. So the risk is extremely low just on the basis of a niche. The risk is extremely high when you have a CSP or you have a placenta previa in a woman with a previous cesarean section.
Fantastic.
So nothing.
Baski, that was really useful, and I want to be really clear on that message, because there's a lot of questions coming through about, well, we see niches, we see these niches, should we be repairing them? The answer is no. Please don't subject your women to an operation to fix a radiological image, but be aware that they do have a slightly higher risk of C-section scar pregnancy, so bring them early in the next pregnancy in order to have a look. Davo.
I just want to make a comment. I'm not sure what Judith practices, but we don't repair many niches, and there are even fewer surgeons who are happy to send patients back to look at the uterus. But I can tell you, in London, with very, very high quality surgeons, when I see niches back after the operation, they're either the same, little bit better, or worse. So we need to be very careful to not to assume that repairing niche is something going to be perfect. We need to have a good audit of the results, and we also need to have surgeons who are actually really properly trained to do that.
We don't want to create one more niche from which was a smaller. Now you create a bigger niche in there after doing the surgery. That's exactly what we don't want. So don't touch those niche.
Okay, Baski, I think you should share your QR code, and gradually what we can do is maybe wrap up the discussion. I'm really super pleased about this webinar today, not only because it's given such brilliant information, practical and pragmatic information, and thank you, Ilan, for I think it's the first time I see a surgical trolley in a slide, and it was really helpful. But also, I think what stood out for me is this call to arms to these 4,000 people who've been online today. We have an incomplete understanding of what is a difficult condition, and it's in your hands, our colleagues around the world, to register those cases in an unbiased fashion. Please, always very important for any registry. Don't put on your favorite 10 cases that went brilliantly. Put on all your cases, ugly, bloody, however they are. They all need to be on there, or none of them have to be on there. So a registry, very, very important not to introduce bias. Baski, I'll let you close, I think.
Aris, thank you. Thank you so much. Okay, I'd like to thank all the speakers here today. Really, it was an excellent session. We had Judith talk about niches and about diagnosis of CSP, Ahmad talk about expectant management, and then the dual team of Davo and Timur who told us really about their opinions about how surgical management should be undertaken. What's absolutely clear from what we have from the CSP registry so far that Laura and Andy presented is that there's real uncertainty regarding allocation of expectant versus termination pregnancy. We don't know what to tell the women, and women are making choices based on variable data. Secondly, the published data on efficacy and safety of methods of termination are not consistent and may not be applicable to different hospitals and centers, because different hospitals and centers may be seeing women at different gestations, different vascularity, and whether or not the fetal heart was present. And therefore, we really need safety and efficacy data to be evaluated in the context of these confounders of type of CSP, HCG level, residual myometrial thickness, heart activity, etc. And therefore, we need a large registry for that. So how can you help us? It's really simple. Get your phones out now, because there are 2 things you can do to help us. The first is, if you have more than 10 CSP cases in the last 3 years, then please click onto our registry here, which is the CSP-registry.com, CSP-registry.com, and just fill in a very short form, and Wilhelm will get back to you, and we will try and onboard you as quickly as possible. But you need to have 10 cases in the last 3 years and an ultrasound image for each of those cases so that we can validate the diagnosis. Secondly, more important than that, or equally important as that, is that we have a short online survey on CSP management. We would encourage all of you, irrespective of whether you've seen 0 CSPs, 1 CSP, or 50 CSPs, please get your phones out and scan this QR code on the left-hand side. It is for a short online survey. It'll take you no more than 10 minutes. And it just asks simple questions about the diagnosis, the prognosis, and also the treatment of CSP. And I would urge all of you, irrespective of your level of experience, because we ask for your level of experience within the survey. And these are the two most important things you can do for us today. It leaves me, the online code survey code is still there. Really, really important to thank not only the speakers, but here is a chart that shows most of that shows the 19 centers and the vast majority of the 35 onboarding centers. And without these clinicians from these various units who included their data in the registry, we would not be here. But what we're looking for really, really is more interest. And as Aris said, we want every single case. Remember that all of the cases are anonymized and de-identified. So when we look at it, we don't have any idea about the cases or the women. We have no idea at all. But this shared collective database is a way out of this quagmire that we currently have about the management of CSP. Thank you, everyone, for your attention and for staying with us for being 20 minutes over time.
Aski, thank you so much. Ilan, thank you so much on Passover, joining us, and happy Passover and happy Easter for all the people who are celebrating Easter next week. Thank you. He's doing a survey already. Because of Easter, our next webinar will be on the 10th of April, and it will be on everyday aspects of gynecology. I look forward to seeing you all there, and I thank all the speakers today, Baski and Prashant, for co-chairing with me. Have a nice day and a nice weekend. Bye-bye.
Bye.